Good morning. We're so happy that you have joined us. My name is Laurel Holmes, and I am co-chair of Healthy Bodies, Healthy Minds, Washington County's Health Equity Zone. It's my pleasure to welcome you along with Allison Croak, the chair of the Behavioral Health Planning Committee. Healthy Bodies, Healthy Minds is one of Rhode Island's 10 health equity zones. Our charge is to collaborate to transform community health in Washington County, and our mission is to advance the health and well-being of Washington County residents through collective community action to address disparities. Today is a really important day for us, as we're launching a plan of which we're truly proud. We all know that mental health is essential to our well-being. Half of us are likely to experience a mental illness and or substance abuse disorder in our lifetime, and 20% of us will have a behavioral health need in any given year. Here in Washington County, the death rate due to mental and behavioral health disorders is higher than the nation, and it is increasing. The percent of Washington County adults reporting excessive drinking and the percent of driving deaths due to DUI is significantly greater, roughly 1.5 times greater than in Rhode Island overall and in the nation. The mental health hospitalization rate for Black non-Hispanic residents is double the rate of hospitalizations for white non-Hispanic residents. Washington County has a significantly higher rate of newborns having neonatal abstinence syndrome than the rest of the state. We also know that Washington County's service delivery system is inadequate to meet the needs of our residents, and as a result, increasing numbers of people seek help at our hospital emergency departments or experience crises that involve local police departments. And it goes without saying that 2020 is not an ordinary year. As we release this plan, the COVID-19 pandemic is further eroding mental health, and residents of Washington County are experiencing rising levels of anxiety, depression, and substance use. Those are just some of the reasons why this plan is so important. I'm now turned to Allison Croak. Allison, are you having difficulties with your audio? Yes, okay. All right. One moment. We're especially proud of this plan because it was developed by consumers and families with lived experience with the system. And this was a big priority for us because we wanted to make sure that consumers, people in recovery, and their families decided where we should start and what our priorities should be for the next 3 years. To accomplish this, we created a local consumer and family advisory committee to guide and inform the process. This group worked with a facilitator to create a plan using the latest data that was driven by the voices and perspectives of people with lived experience, including their own. In addition, approximately 40 consumers or families with lived experience participated in focus groups that explored their perceptions of behavioral health and substance use in Washington County. All of their voices and solutions are reflected in this plan, and for that, we have many people to thank. Thank you to the Consumer and Family Advisory Group who spent many hours hashing out the issues, setting priorities, and identifying strategies. I especially want to thank Jim McNulty and Marcia Boyd. This plan would not have happened without their leadership, insights, and advocacy. Both of them brought their own personal lived experience with mental illness to the table as members of the Behavioral Health Planning Committee. And then they stepped up to co-chair the Consumer and Family Advisory Committee and spent hours and hours of their personal time helping us to bring this plan together. In addition to volunteering his time with us, Jim is the executive director of the Oasis Recovery and Wellness Center, and Marcia is an attorney and on the board of NAMI Rhode Island. We cannot thank you enough. I also want to thank the core team who managed the process and oversaw the writing of the plan to ensure clarity, consistency, and viability across the plan. Thank you to Susan Jacobson, the project director, Susan Orban, the director of Healthy Bodies, Healthy Minds, Liz Gledhill, the project coordinator, and Kristen Lahoulier of Elevated Results Consulting, who facilitated the process and writing of the plan. There are so many other people to thank for helping to bring this together, including the Behavioral Health Planning Committee for their commitment to making sure this was a consumer-driven plan and their leadership and oversight. Rhode Island Foundation, Healthy Fund for Rhode Island, and Rhode Island Department of Health, Opioid Prevention Planning, for funding the work. The University of Rhode Island for focus group recruitment and facilitation. And the Steering Committee of Healthy Bodies, Healthy Minds for helping the team make connections in support of the planning process and plan and final approval. And now I'm going to hand off to Jim McNulty to introduce the plan.
Me. Well, I think I'm live, yes. I've been living with bipolar for most of my adult life, which is about half a century now, and I've been part of more advisory committees than I can easily recall. I stayed with this one mostly because the provider community in Washington County is committed to helping realize it along with the members of the committee. Our big goal for this plan was to move toward a trauma-informed, recovery-oriented system that is peer and family-driven and designed with and accountable to people with lived experience of mental illness and substance use and their families. Peer-driven and recovery-oriented are terms that most of you are familiar with, but that does not mean that we all have the exact same idea about what these terms actually mean in bringing a system to fruition. But these concepts are at the very heart of the changes we need to make. David Covington is an expert in this, and he's going to talk about this and the importance of a peer-driven system and how we move towards it in a little later on. But before that, we would like to share the details of our plan. We have 4 members of the Consumer and Family Advisory Committee here to introduce the 4 pillars of the plan. So to start, please let me invite Erin Goodman to talk about the first pillar, which is culture change. Now, we will be taking questions and answers at the end of the presentation. You can submit your questions using the Q&A button throughout the presentation. Erin?
Thank you, Jim. Good morning. My name is Erin Goodman, and I am the peer recovery specialist for the Washington County Zero Suicide Program. I'm an employee of Wood River Services, a lifelong resident of Washington County, and the mother of 2 teenagers. I am also a person in long-term recovery of 7 years from a severe mental illness and related substance use, as well as a person who lives with clinical depression, which I manage with the help of wonderful behavioral health professionals. So I come to this work as a professional, a community member, a parent, and a consumer of behavioral health services. And I'm going to speak briefly on the importance of creating positive culture change within our healthcare system and our communities. When we talk about culture in this context, we're talking about the prevailing beliefs, norms, and values that we hold about behavioral health. Our priority goal in this area is to reduce stigma and fear of seeking treatment by individuals and families who are in need of behavioral health services. And in working towards identifying this priority goal, people like myself, who are consumers of behavioral health services or family members of consumers, shared our experiences. We shared stories of experiencing discrimination, ridicule, criminalization, being labeled and stereotyped, not being taken seriously when seeking help, financial hardships, and meeting one closed door after another. And we shared hopes of experiencing parity, respect, empathy, empowerment, understanding, support, and connection. This is about changing the culture, changing the prevailing beliefs, the norms, and the values that we, both professionals and our communities at large, hold about behavioral health. We want to make progress in this area by normalizing and promoting mental health awareness, increasing the number of towns committed to training residents in mental health first aid, and implementing with fidelity zero suicide across healthcare organizations in Washington County. I am especially excited about 3 initiatives we're working on in this area to positively change the culture around behavioral health. One is a new 8-week support group for suicide attempt survivors that I help to co-facilitate. The second is called Man Therapy, and it's an initiative to engage working age men, age 24 to 54, in behavioral health care, and that's being spearheaded by Dr. Rob Harrison. And number 3, a new campaign being led by the Charahoe Youth Task Force, where beautiful wooden signs with QR codes are being placed in remote areas where residents have been known to engage in high-risk behaviors and attempt suicide. This is not easy work, and as we all know, COVID-19 has increased the need for behavioral health services and made the delivery of these services more challenging. But I am extremely optimistic, especially when sitting with a team like we have assembled here today. We're up for the challenge, and we're committed to positively changing the culture around behavioral health in Washington County. And I'd now like to turn things over to Magni, who will speak about the pillar of self-determination and inclusion.
Good morning, everyone. My name is Magi Gomes, and I'm a community health outreach worker at the Johnny Cake Center. I'm also a member of the Consumer Advisory Board. Today, I'm here to discuss self-determination and inclusion. After attending a few meetings, I have learned how important it is to listen to many different voices, expressing their concerns, and also sharing information that can be useful to others. We need to be accountable to those who need services. People need to be respected and, most importantly, listened to and understood. Consumers want to have a relationship with their providers and guide their helpers to provide care that meets their individual needs. The Consumer Advisory Board is an important part of improving behavioral health care because it gives voice to the lived experience, both positive and negative, of those who need and benefit from the services. Healthcare services should be done with you, not to you. Partnership and good communication between professionals and their patients is a foundation for quality care. And now I pass over St Laurent that will introduce our next pillar.
Hi, I'm Sarah St Laurent. I'm a resident of Washington County. I'm a person in recovery also. I work at BHDDH as a community relations liaison. The third pillar of this plan is parity in treatment, with a goal of improving network capacity, quality, and accountability along a full continuum of care. Objectives include advocating for insurance parity and increasing access to high quality services and supports. It's one thing to academically understand why this is important, but it's another to have an experience yourself of why parity is important. So I'm here today to tell you why parity is important to me and what made this real for me. On November 10th, 2017, my mother, who was still actively struggling with addiction, died unexpectedly. I had not talked to my mother in 6 years before her death, and I didn't realize how deeply it would impact me. I was devastated and surprised. Shortly after getting that news, I started having trouble at work. I was working on a grant-funded program that offered treatment to youth and young adults with behavioral health issues, and I suddenly wasn't able to keep my emotions out of that work. I was getting triggered by some of their experiences. I was having trouble focusing on the admin tasks I needed to do, and I was having flashbacks and panic attacks. I had been out of therapy for a little while, but I knew it was time for me to go back. I connected with EAP through my employer, and they connected me with a therapist, but couldn't find me a prescriber that could see me in the next month. As a last resort, I called my PCP, and it turned out they did have a prescriber on staff with a cancellation, so they were able to get me in within the week. I went to my appointment and told the prescriber everything. I explained why I was there. I was forthcoming about the history of addiction in my family and my fears about that. And I told her I was back in therapy, but I wanted a one-time prescription of Xanax that would last me just a week or two to tide me over until I could get more therapy sessions under my belt. As soon as I brought up a medication, her whole demeanor changed. It was like a door in her head slammed shut. She said it sounded like I was med seeking, and as addiction ran in my family, she could see how I could be an addict who was coming around looking for pills. She said something about, only addicts know the exact name of the pills they wanted, even though she knew what I did for my job. She insisted that I took a drug test that day or she wouldn't prescribe me anything. So I took the drug test and it came back, clear. And yet she still ended up refusing to prescribe me anything. So I left that appointment feeling very deflated, still struggling. I saw my therapist the next day, and after sharing my experience with the prescriber, he ended up recommending I take a leave of absence and double up on therapy sessions until I could get myself, back where I needed to be. So I took his advice and I was out of work for 6 weeks. Clearly, I'm here speaking with you all today. So I made it through that experience and I'm all right, even though I didn't get what I asked for from my prescriber. I took time off and I worked my recovery. I went to therapy twice a week. I dove into my wellness recovery action plan and did everything I needed to do to get well and stay well. However, it was a huge privilege that I was able to do that. I was lucky enough that I had savings to cover my expenses during that 6 weeks of unpaid leave. And I was lucky enough that my job allowed me to take that unpaid leave without fear that my job wouldn't be there when I came back. But what if I didn't have those things? I would have had to keep going to work while I was struggling, and I could have lost my job because I couldn't do my job the way that it needed to be done at that point. No one should have to go to providers like I went to and deal with being discriminated against because there's no one else to go to. And people shouldn't have to choose between their health and well-being and their employment either. I was lucky enough that I didn't have to, but some people are not so lucky. We know that good mental health is essential to leading a healthy life. Someone said that earlier as this started. And yet mental illness and substance use disorders are leading causes of disability and premature death in our country. After my experience, I can see how easy it is to go from a person struggling with a mental health issue to someone who's disabled by that mental health issue because they can't get the help and support that they need. I hope that my experience demonstrates to you why parity, especially the part about quick access to high quality providers, is so important. Thank you for giving me an opportunity to share my story. I will now hand it over to Mike Fry to talk about the crisis system.
Thank you, Sarah. I appreciate you sharing your personal story. Thank you. So my name is Michael Fry. I am the Director of Parent Support Network and Hope Recovery Centers and also a resident of Washington County. I'm also a certified peer recovery specialist. Most importantly, I'm a person in long-term recovery from substance use disorder, and I'm here to present the fourth and final pillar and how we are continuing to address the gaps in the crisis system. So one of the objectives is that behavioral health is treated as a public health issue and not a criminal justice issue. I think we have all heard that the saying that we cannot arrest our way out of the addiction epidemic, and I definitely concur. First responder approaches like crisis intervention training and teams, which are already in place, have resulted in better outcomes for crisis encounters in Washington County. The CIT model is designed to improve first responders' ability to safely intervene, link individuals to mental health and substance use disorder services, and divert them from the criminal justice system to treatment and recovery resources. this is definitely a positive shift in thinking. And, you know, even thinking back on my active addiction, when, you know, when the police came to my house, my active addiction, they definitely weren't there to help me. So I appreciate what the change that's being made and you know, the positive shift. I spoke a couple months ago at a crisis intervention training at the South Kingstown Recreation Center about my personal recovery, and more importantly, about some of the resources for recovery in Washington County, and was just left there very impressed with the interest, engagement, questions from members of the police departments from across the state. All the people in attendance were voluntary, so that tells me that we are shifting in a positive direction, as I mentioned before. I'd also like to say that over the years, I and others on my team have had positive interaction with all the police departments in Washington County, from Chief Corrigan, Chief Lacey, Chief Johnson, and a lot of the other officers and sergeants across the state have had very positive interaction. Another objective is to improve patient experience across the crisis system by including peer and family supports. If I had to say what a peer recovery specialist is in one sentence, which I kind of have to do because I'm on a time frame, it would be you know, someone with lived experience of struggling with both substance use disorder and or mental health challenges that is in recovery and have changed their lives for the better and want to help others do the same. I've had intimate experience of working in crisis situations as a certified peer recovery specialist in South County and Westerly emergency departments, and on a mobile street outreach team over the last 6 years. You know, what an honor and a privilege to be able to go into an emergency department after someone has just experienced an overdose and give them hope and let them know that recovery is possible. To say that I've been there and I know what you are going through and actually mean it, and identifying with them on a non-judgmental personal level is amazing, and it can quell some of the combativeness, fear, and anger that individuals may experience during a crisis, and can truly change the course of someone's life. I would be remiss if I didn't mention that the system in place now is less than ideal. Our plan calls for expanding the number of peer recovery specialists that live in Washington County to work in South County and Westerly emergency departments and behavioral health units, and increase access and connection to local recovery support services. Lastly is to coordinate follow-up and bridging gaps to treatment, which includes a community care team that connects patients to local resources and linkage to care after discharge. We are also looking into working on a 24/7 crisis triage phone line for Washington County residents, and also exploring the feasibility of a behavioral health crisis center in Washington County as well. Thank you all for your time, and I hope you enjoy the remainder of the presentation. I think you're on mute, Susan.
Okay, I'll start over. Sorry about that. I thought I was unmuted. So I just was saying thank you to all of you, to Erin, to Magni, Sarah, and Mike, and especially to my good friend and colleague, Jim McNulty, as well as Marcia Boyd, the co-chairs of the Family and Consumer Advisory. It has been such a privilege to have led this process over the last year and work with consumers and people in recovery and family members to craft this plan. There have been opportunities to begin to implement the plan, in particular around the crisis system, which Mike Fry mentioned, and the rollout of CIT and some other initiatives to improve the experience of people with behavioral health conditions and their families' experience with police departments in each community in Washington County. And I'm really proud of that work and thankful to the many community partners who've been helping with that work. We have a steering committee for that work that includes the chiefs of the police departments in Washington County, and then also the Police Chiefs Association for Rhode Island. So I'm really grateful and enthusiastic about the levels of participation and excitement in the justice system, and particularly among law enforcement professionals. I think one of the things that I'm really excited about in this plan is the focus on inclusion, and so it's with. We have about 5 to 10 minutes for questions and answers, or I don't see any in the chat. I'll give just a minute in case anyone has questions. If there are no questions at this point, we can transition to our keynote speaker, David Covington. Let's just give one more minute. And if there are questions that you have, you can certainly hold them. We'll have another Q&A session after David Covington has finished the keynote, and questions about the plan as well as questions for David can be included in that time. I see one question just popped up from Marion Fowler. Are there plans for IOP or PHP programs, so intensive outpatient or partial hospitalization programs? So I can answer that to the best of my ability. All of the behavioral health and healthcare providers, organizational providers in the county have been a part of the Behavioral Health Planning Committee since 2016. And there has been discussion of intensive outpatient programs as well as partial hospitalization programs, higher levels of care here in Washington County. There also has been discussion, as Mike Fry mentioned, of a diversion center that might offer a continuum of care that would include a day partial hospitalization or intensive outpatient program. So there's interest among providers in developing those programs or supporting those programs. The big challenge that we've had has been around parity in rates for reimbursement for those services to make them viable fiscally. So, so the answer is yes, we would like to do that, but we need to continue to work with policymakers and payers in order to provide a continuum of care, a full continuum of care for Washington County residents. See another question. What recourse do we have when someone experiences something like Sarah experienced with her prescriber? Could she have gone to Ripen? So that was from Corinna Roy. Thank you, Corinna. That's a great question. Yes. So the Mental Health Association, in partnership with Ripen, have rolled out a parity initiative, and there are resources through that Rhode Island Parity Initiative to not only report an experience of a parity violation, but also to have assistance and guidance. So yes, thank you. And some of those resources are in the plan as well. But I think one of the points that came up really clearly in the Family and Consumer Advisory discussions over the months was that it's not really all that clear what kind of recourse or what kind of accountability to parity individual providers have. And so that's something I think when someone has an insurance plan, you expect to be able to call up that insurance plan and say, hey, here I had this experience within network, or have a clear pathway for questions, concerns, and recourse. And so that accountability to consumers and people who are using the behavioral health system is a key, a really important key to and priority for this plan. And we heard it loud and clear from consumers and families that while the law does outline that there should be parity, and it is the law to have parity, what to do when you've experienced something that you think might violate that law, it isn't as clear as we'd like it to be. But initiatives like the Parity Initiative are helping us to do that. So there's one more question, and then I'm going to introduce David Covington for our keynote address. Lynn Bryan Phipps asks, will we have an opportunity to connect with the people in this call? Perhaps receive a list of participants or emails to reach out to in the future? What a great question, Lynn. I was thinking as we got on today, and I was looking at all of the participants. I think now we have over 70 people on this call, and thinking, wouldn't it be wonderful if we were all in one room and we could talk to each other, have a cup of coffee, you know, pass cards. You know, there are many people on this call who I know and others whom I have not met yet. And I thought just the same thing, that wouldn't it be nice if we were all in person? So Healthy Bodies, Healthy Minds does have a platform for community networking and community engagement. So we will send out that information, as well as information about how to connect with people on this call and how to connect with others who want to advocate for and support this plan and advocate for mental health and inclusion and self-determination. You know, one of the primary goals of the plan in the self-determination and inclusion pillar is to foster a movement for mental health and for recovery and for behavioral health in Washington County. And so connecting with each other in order to do that is really, really important. So thank you for those questions. With that, I'd like to transition to the keynote with David Covington, the keynote moving towards a truly peer-driven system. David Covington is CEO and president of Recovery Innovations Incorporated, also known as RI International. He's a behavioral health innovator, entrepreneur, and storyteller. He's also a partner in Behavioral Health Link and founder of the international initiatives Zero Suicide, Crisis Now, and Hope Incorporated. I met David at the Crisis Intervention Team, or CIT International conference in Seattle last year, and where he also gave the keynote address, and was just blown away with his stories, with his presentation, and with the rigor of his plans. And the accountability at the person level with which his work really, continues to center. So with that, I'm going to pass the mic over to David, but just to know that there is time for Q&A at the end of his presentation. You may post your questions in the Q&A chat box at any time through the presentation, and we'll be keeping track of that. So with that, I'm going to pass it to you, David, and thank you so much for joining us here in Rhode Island.
Thank you so much, Sarah, Jacobson, and Corbin, and our Rhode Island team. It's a pleasure to be here. And when I look at the feedback from plans like this, to me, you always have a focus on quality and compliance, but the degree to which you've engaged lived experience is going to impact the way it feels. And the way it feels comes from a focus on suffering, on courage, and that comes across in this plan in spades. And I want to really say a huge thank you, Jim, Erin, Magni, Sarah, and Michael, for the time and effort that you put into working with the teams on this plan. It looks like a tremendous foundation for moving care forward in Rhode Island. I want to start with a story of Dr. Donald Berwick, who Erin was talking about the Zero Suicide effort. Sarah also referenced that work. Zero suicide would not exist were it not for Dr. Donald Berwick, who, with the Institute of Medicine, wrote a paper called Crossing the Quality Chasm. And he's the one who really began to focus us on care being safe, effective, cost efficient, and there being a joy in this work that we all do together. It began to really put a focus on the outcomes of a U.S. healthcare system. By far, GDP of France does not equal our healthcare system spend. And yet the outcomes that we routinely get from that place us barely inside the top 20 in the world. So he began to focus on this with the Institute for Healthcare Improvement and the Institute of Medicine. But in large part, it came from, as many of these things do, it came from his own lived experience with the health of his wife and a near fatal condition that she went through. But Dr. Berwick recounts the story of a friend who began experiencing chest pain and had to go to the hospital for a catheterization or a cardiac catheterization procedure, and she was afraid. And she asked Dr. Berwick, who's a renowned pediatric physician and also policymaker, who went on to lead the American Medicaid and Medicare system, but was already well nationally known at the time, that he visits the hospital with his friend who's afraid. And she says, I would feel so much more comfortable if you would go with me into the procedure room. And he said, of course, I'd be happy to, whatever you need. And so the nurse said, wait, what's that? And the woman said, I'd like Dr. Berwick to accompany me. And so she asked, well, Dr. Berwick, would you be going in as a friend or as a doctor? And he said, well, I guess it would be both. And she said, well, we have a policy against that, so we wouldn't be able to do that. Now, if you're going to say that you have a policy against something, it might be good to say that to someone who's not Dr. Donald Berwick, because he was aware that likely was not a policy. So the physician came in and said to the woman, I understand you would like Dr. Berwick to come back with you. Can you tell us why? So they pressed on the situation, and ultimately the nurse and doctor said, look, we're just not comfortable with that approach. And Dr. Berwick says, well, have you ever tried it? And the answer was, again, no. And the woman was wheeled away, sobbing, shaking, and afraid. As for all of us who've been into the hospital or in for concern about our health, these issues of humanity, of engagement and respect are easily glossed over. Now, look, if there's a committee that were to review that, let's think about the composition of that group. If it's a regular group of professionals, they'd likely look on that situation and say you had a couple of individuals pressing against the good judgment and experience of the medical staff, asking for special treatment, looking to go outside of established parameters and procedures. And yet, or substance use or suicide, this is a human situation that should go across our healthcare system. Now, Dr. Berwick went on to actually publish about almost 11 years ago now, a report he called What Patient-Centered Care Should Look Like. And he called it Confessions of a Fanatic. And I want to read just briefly something he wrote in that paper. He said that the power of care design from the people providing care to the people receiving care. Here's exactly what it says in the paper. Real patient-centered care should involve a radical, unfamiliar, and disruptive shifts in control and power out of the hands of those who give care and into the hands of those who receive it. What Dr. Berwick is proposing is something that's not just your usual enhanced approach to quality. It's an engagement of people who've lived through this in ways that are fundamentally different and yield a totally different experience. And again, we're talking about the entire healthcare system, not just for behavioral health. So let's talk about the way that things happen in response to a healthcare need. And the field of psychiatric rehabilitation has come up with this little progression of stages, if you will. And the first one in their list, you've already heard it referenced by some of our speakers, is a system can be characterized by doing things to someone. Now, usually when a presentation age of intensive care, of state hospital facilities, of large campuses with tens of thousands of individuals who are put together, and Mental Health America, large national advocacy group, years ago when Jimmy Carter was president, they worked with Rosalind Carter, and they made a actual freedom bell, a liberty bell that came from the where they'd gone into the backwards of state facilities, and they had taken the shackles that were used to restrain individuals, and they melted those down and actually forged a liberty bell, a mental health liberty bell. So it's easy for us to look back and say, well, that's the way things were back in the 50s and before, when the primary way that we treated individuals was we did things to them. Electroshock therapy, forced hospitalization, et cetera. But that'd be way too comfortable for us to just look back. Let's take a moment and let's reflect on it with I'm actually part of a group that came out of the 21st Century Cures Act called the Interdepartmental Serious Mental Illness Coordinating Committee, or the ISMIC. And 4 years ago, we were brought together by Congress to report, and the Secretary of Health and Human Services at the time said, let's do a candid and sober assessment of where we're at. Let's take a look at where we're at. Every day in the United States, we have 20 to 25,000 people whose needs are so great that they themselves or someone else either calls 911 or a local crisis line, or they walk or drive to a local hospital emergency department. Now, they're aware of discrimination and stigma. They're concerned about what might happen, but they're fearful. They're so afraid of what's going on in their life. Maybe it's the first time they've experienced psychosis. Maybe they're so afraid of what they might do to themselves that they reach out anyways. And the predominant way that we respond to those individuals, if there's a call to 911, then law enforcement is going to show up on the scene. Now, again, take a regular healthcare situation like Dr. Berwick's friend who's concerned about her heart and going back for this catheterization, and compound that by a factor of 10. Take the anxiety you feel when you're driving on the freeway and lights from a patrol car signal you to pull over. Take that up. You're at your home, you're at your apartment, you're wherever you are, and law enforcement drives into the driveway, 1 or 2 vehicles, and a uniformed officer knocks on your door. Now, the 911 gets 240, 250 million calls a year. The best estimate we have is that 10% of those calls are for someone with a mental health, a substance. The most common response is to dispatch law enforcement. Law enforcement is then going to try to take the person somewhere. They're going to take them to the hospital. They're going to take them to try to get care. And in our experience, about 70% of the time, they're going to put that person in handcuffs. Again, think back to the nurse saying, that's not our procedure for you to go back. It's not law enforcement's procedure for for an individual to be put in the back of that police car and not to be handcuffed. Depending on the situation, they can have shackles put on their feet too. That's less common in our experience, but it's the most common experience. For many jurisdictions, it's just a protocol. So again, if I'm the individual, or it's my spouse or child or parent who's being engaged, then the experience is going to feel to us not just alone and scared like the woman who was being wheeled down the hall, but now it feels like punishment. It feels like, at least from our experience, it's akin to someone who's being arrested. Now, that's only where it starts. The law enforcement officer is then faced with, do I take that person to an emergency department, where at minimum, they're likely to be 2.5, 3 hours longer than if they simply took the person to jail and booked them into some kind of nuisance crime. And I could go on. The report that we shared with Congress back in 2017 reflected on the health situation for people with more serious mental illness in the United States. And it's akin to someone living in Afghanistan. They're dying at ages 45, 50 to 55 for a host of medical issues, many of which are either caused directly by or related to the treatments that we give. Diabetes and heart disease are common. Obesity is common. The social relationships, connectivity of these individuals is challenged by virtue of the situation that we've just talked about. So doing things to people has been the foundation of what the mental health system in the United States came from. And it continues to permeate our approaches. Now, again, I'm going to draw on Dr. Berwick one more time. It's easy for us to say, and I commonly hear it heard, well, our mental health system is broken, it's fragmented, and so we patch together hospitals and law enforcement to make do. Dr. Berwick, being the systems thinker from the Institute for Healthcare Improvement, says that systems are perfectly designed to do exactly what we want them to do. The discrimination and stigma that was referenced by our 4 speakers to start influences all of this and shapes the way that we as a society respond. I was with 3,000 psychologists, mostly from Europe. And I gave a presentation and I asked one of the speakers in the room, how many of these psychologists here at this conference are likely to have made a suicide attempt themselves or seriously contemplated suicide? And Roy O'Connor is one of the top researchers in the world in this space. And he said probably 15%. So 450 individuals at that conference. And I asked, how many of them have shared with anyone, talked to someone about that, or they're open about that struggle? And the answer was, well, there was a time it was 0. It was just none. And today it might be 10% of them. So we're talking 400, a little over 400 who at a psychology conference, if you can't share about those kind of challenges when you're a psychologist, and it gives you a sense of where we're at. So doing things to people creates a set of reactions, responses, and outcomes that is consistent with what we've described. Now, psychiatric rehabilitation does acknowledge that we've moved in many systems to a less invasive, less intrusive, and it's much kinder. It's more compassionate, and yet it's a little bit caretaking. It's a little bit of a dependency situation characterized by doing things for. So in the 60s, we started to move away from a institutional system to a community mental health system. But largely, that system still focused on doing things for individuals. A few years ago, we went through the Great Recession, and there was a massive reduction in services here in Arizona. I was with the health plan at the time responsible for behavioral health, and I went around to about 30 sites and talked about what was going on to individuals who were reliant on a host of key services that were being eliminated. And I was in one of those forums, and a certified peer coach stood up and said, look, this could be a good thing. And he said, hear me out. He said, for years, my mother was my coach, my case manager, my navigator. In some ways, she was my clinician and physician. And I could barely get by without her. I could not conceive of a recovery that she wasn't a part of. And then she died. And he said, at first I was so afraid. And he said, but now looking back a few years, he said, I hate feeling this way. It makes me feel guilty that I didn't when she was in my life. And he said, the only thing that I can think about related to that is that I was comfortable with her being the one driving the car. I was the passenger. And when she passed away, I was forced to move into that driver's seat and to begin to take control, take responsibility. And ultimately, he said that 2 years went by and the recession started to lift and we began to restore the services, some services. We began to receive funding back from the governor's office and the health department. And we went back and evaluated the outcomes. We had an algorithm because we were continuing to track those individuals. They had a scant generic medication benefit in the new reduced environment. But it meant that we still saw them. We saw them infrequently, but we had data about their hospitalizations, their incarceration, their social connections, their outcomes, their assessment from a physician, et cetera. And what we found is that for the vast majority, and these were individuals with serious mental illness, the vast majority, over 90%, fared slightly better with the reduction of all those things we were doing for them. Again, from a kinder position, and yet not getting the outcomes that we're looking for. Now, psychiatric rehabilitation says, let's not do things to people or for them. Let's do it with them. They're the driver. We're a co-pilot. We're a support. Dr. Madeline Gould out of Columbia University did some great research back about a decade ago now, studying crisis call centers. And she asked them about, do you do things with? Do your clinicians or your consultants on the phone, do they share their personal experiences? And she actually worked with 16 crisis centers, all 16. The leader said, no, we don't engage in that kind. That would be oversharing. That would be a breach of a professional boundary. So we don't do that. That's against our policy to have that kind of self-disclosure. And then she listened into thousands, silently monitored thousands of phone calls and found all 16. All the centers, of course, individuals shared. They also did a factor analysis. So the data, the algorithms behind the scene showed that was actually one of the most effective things in terms of having an impact of getting alongside of a human connection and engagement. So doing things with is not just the right thing to do. Dr. Berwick didn't put forth patient-centered care because he thought it was cool or human or the right thing to do. He actually put it forth because it works, because it creates a different set of outcomes. Now, we've begun to think about this a lot over the last decade, and doing things with, from a professional standpoint, if it's all doctors and nurses and clinicians and they're doing it with us, it makes a difference. But what if there was somebody on that team that was a certified peer coach or a person with lived experience? Brene Brown was saying this long before the era we're in now, and certainly it's been adopted by people of sexual assault and sexual harassment. But Brene Brown said the two most powerful words in the English language are "me too." When someone has lived our experience and been there and connected with a similar sort of challenges and suffering and courage, creates something altogether different. I was actually at Magellan Health, and we were bringing peers to the table. We were bringing people in to help us design the work. And I had the opportunity to meet with Phil Pangrazio. Phil led an organization, used to be called the Disability Empowerment Center. Today it's called Ability 360. And I walked up to him after a presentation he gave at a local NAMI. It was very inspiring about work in the disability space. We're doing it at Magellan. And as I was watching him, I was seeing this look of disgust on his face. At one point, I actually thought he might spit. And I was like, wow, I think I put my hand on my mouth. And he said, David, let me clue you in. He said, in our space, we don't get invited to the table. We run the table. We're the CEOs. We're the chairs of the board. We invite people like yourself, clinicians and others, to consult and work alongside. And I began to really contemplate this idea of a peer-driven system. One where it's not just a single clinician or a token representation of a peer, but it's a number of peers who are engaged in that team. At Recovery Innovations. Look, RI, we're just made for a presentation in Rhode Island, aren't we? But Recovery Innovations, when I came to the organization, had been transformed into a peer-driven approach. Now, I don't know what the exact number of peers that it takes to transform something. I think about, if we think about water, for an example, water at 40 degrees is really cold. At 35, it's even colder. But at 32, a cataclysmic change happens. It's a disruptive and explosive kind of change, and the water freezes. So there is a percentage of peers, one or two token individuals carrying the weight of lived experience in a larger team. That's not transformative. It makes a difference. But it's not transformative. There's a percentage, I don't know, maybe it's 20, maybe it's 25%. Back when I was working with Magellan, after talking to Phil Pangrazio, we began to infuse into medical clinical teams, into ACT, now ACT has it built in already, but into our teams overall, we began to infuse both peer and family engagement in huge proportions. We had one site in just east of Phoenix that had about 1,500 individuals who were served at that site, about 70 staff, and they had one peer coach, one family support staff prior to us beginning to move toward a peer-driven system. And we looked to 25 or 30% of the staff beginning, and we added new positions, new funded roles to integrate with and work in conjunction with that peer team. But when I joined RI had already shifted far beyond that. The company was founded out of a garage in Arizona in 1990, began to grow and as a traditional community mental health center focused on crisis care. When in the mid-90s, my predecessor heard a presentation on psychiatric rehabilitation from Dan Fisher, a focus on what's strong, not what's wrong. Psychiatric rehabilitation says symptoms and functioning are important as they relate to the person's hopes and dreams. If someone's has a mental health challenge that includes psychosis to the point that they hear voices, voices are a challenge if they keep the person from achieving their goals, and only then. If they keep them from the social connectedness that they want, if they are a barrier to them achieving success at work, if they are bothering the person and the person wants to address them, then that's part of the challenge. But the challenge is not those things. The challenge is, what do they want to achieve? What do they want to do? How do they want to be? So he heard that presentation and began to hire not just a few, but began to, in fact, hire hundreds of individuals, one of the first organizations in the country to begin to do certified peer specialists, to do training. We call it peer employment training because we're training individuals for a job, for engagement. Today, we have about 1,200 employees across 10 states. We also have offices in New Zealand, and we're just recently awarded one in South Australia. And those 1,200 staff, when you survey them, 65% report a lived experience of serious mental health challenges, substance use, and or homelessness. These are individuals who've lived that. So how does our organization look different? How has it been changed? Well, the most telling example is the living room approach to crisis care. Individuals, when I first visited our crisis recovery center in Phoenix, I was struck by a few things. First, the language. Individuals aren't patients or consumers or clients. They're guests while they're at the program. And the approach is peer first, peer last. We have 13, 14, 15 times a day. Law enforcement is dropping the person off at the back of our facility at a special door for law enforcement. They haven't gone to a hospital first. They come directly to us. That individual, again, 70% of the time is being let out of handcuffs as they're coming into the facility. They come into a room that is, we have a mural in the room that's warm and welcoming, and a peer is the first person to engage. Just a nurse practitioner, a clinician, or a doc, they are going to meet with that individual, but not until a peer has already engaged them. A peer who many times has actually been in the back of a law enforcement car themselves, transported to a facility. And then they're not just a token sort of peer first, peer last, they're engaged throughout that care of the individual is going to be a part of that discussion. And they're going to see that a peer is going to be engaged. We had an individual a couple of years ago who was standing in the middle of the crisis center, and they began to just scream. And they were holding their hands and looking at their hands and being very, very loud. In most centers, the most immediate response to that would be some efforts at de-escalation, but likely to result in some kind of forced restraint, forced medication, something to calm agitation and anxiety, to get that person under control. In our living rooms, we're going to give space so long as the person isn't a danger to themselves or someone else. But this person was clearly in distress, and we have clinicians, we have nurses, we have physicians, we have everyone that's required. And they're leading the teams, they're key parts of the teams. But this is a peer-driven model, and one of our recovery coaches approaches the individual kindly, gently, asks to engage with them, and they landed up just taking and holding the individual's hands. We learned later that the individual was what they were feeling and sensing was they were seeing blood on their hands related to their mother's death and having a very traumatic experience. And this peer coach, because of personal lived experience of understanding and having a pretty keen idea of what this person might be experiencing, was able to calm that individual. Now, look, if that's the only interaction you had with that individual on their worst day, you would make conclusions about what they were capable of. But that individual ultimately returned to join the staff of our program, go through our our peer employment training, and to become part of the program and begin to move forward. It's transformed our organization and made it something totally different, and one that is bringing hope, a focus on recovery. And again, recovery doesn't mean it's not a miracle that the person, again, to use the metaphor, throws over the wheelchair and rises and walks. It means that all of us have hopes and dreams. All of us can make an impact and a contribution that benefits our family and friends around us. And that's the case whether we have schizophrenia, bipolar disorder, a history of substance use, made a serious suicide attempt. And that happens in conjunction with a full-on team. And it's clearly represented in spades in this plan that Washington County Healthy Bodies and Healthy Minds has put forth. And I'm thrilled to be here today. Thank you so much for the opportunity to share, and very excited about the work that you're doing in Washington County as you move this peer-driven system forward.
Thank you, David. That was phenomenal.
Thank you, Susan.
Thank you so much, David. This is the other Susan Jacobson, and Sue Orban just popped on the screen too. We have a few questions, and I imagine that more will pop up. I noticed, the first question is, I noticed this presentation is being recorded. Will this be placed on the Healthy Bodies, Healthy Minds website? There is some great information being relayed here that I'd like to refer to later and listen again. So that's a question that would need to be answered by Sue Orban, but I do know that this, as to whether it will be on the website, but I do know that this presentation is being recorded and will be available at a later time. I'm not exactly sure which platform that will be on, and here comes Sue to answer that.
So Healthy Bodies, Healthy Minds has a YouTube channel, and we'll post it there.
Excellent. That's great. So Chief Sean Corrigan from Narragansett Police Department wanted to make sure that we shared with this audience here that it is not the standard practice in the Narragansett Police Department to handcuff people in mental health crisis. And that the Narragansett Police Department's mental health response policy is posted on the website, on the police department's website. So thank you, Chief Corrigan. And Chief Corrigan has really been a champion and a leader around rolling out both mental health first aid as well as crisis intervention teams in Narragansett. And, you know, we have members of the Consumer and Family Advisory who have really spoken very positively about the experiences that their family members have had with the Narragansett Police Department, in particular since the rollout of crisis intervention teams in the police department. For example, you know, police officers who are CIT officers making a point to get to know people in the community who may have frequent involvement with the crisis system, getting to know those folks on a good day, being a resource for people who experience behavioral health conditions and so then may be more likely to encounter the crisis system, whether that's the police department, the emergency services system for healthcare, et cetera. So just a well-deserved shout out to Chief Corrigan in Narragansett, you know, as well, Chief Lacey in Westerly, Chief Johnson in Richmond have really been tremendous leaders in community-oriented policing, yes, but then moving to that next level and embracing mental health first aid as well as crisis intervention teams in their departments, and then partnering with behavioral health providers as well as consumers and advocates and family members to roll out crisis intervention teams in Rhode Island. So I have another question here. What steps are in, so it seems, David, that many of these questions are about our plan in Washington County, and that is fine. I told folks that we were ahead of time when we started the keynote, so if there are additional questions about the plan, that's fine, and also to open up questions for David Covington as well. What steps are in place in Washington County to incorporate these types of programs into our health centers? So there is a zero suicide initiative in Washington County, and that zero suicide initiative is being rolled out across the healthcare system with Healthy Bodies, Healthy Minds, and Sue Orban's team at the lead. The rollout in health centers is occurring this year with training for all staff in the zero suicide model, which includes screening for suicidal thoughts and symptoms, and then same-day referrals to a clinician and to develop follow-up plans for people who might be experiencing suicidal thoughts or have a plan for behaviors, suicidal behaviors. Next question from Jim McNulty. Jim says, David, thank you. You laid out the case. Oops. Jim's question just disappeared.
I'm sorry, Sarah, I answered it and I didn't realize that minute goes away. It's under.
Okay, do you want to answer that? You want to answer that live? That would be great if you answer that live.
Oh, well, I just said thank you, Jim, for the work that you and everyone who's involved in the plan. It's a tremendous plan. I can't wait to share it nationally. It's a great platform, and I think will yield really significant outcomes as you move forward.
Great, thank you. And Jim's question was, David, thank you. You laid out the case for a peer-driven system, simply and beautifully, and backed with data and experience. Okay, so here's a question, David, if you would answer this live. What did you find was the biggest obstacle that you faced? Usually, this is Jill DeRico asking this question, and she says, usually I have seen it as funding or buy-in. She's asking you, what did you find the biggest obstacle to be?
Yeah, so look, the funding, if we go back now 20 years, Wendy Tygren and Larry Fricks in Georgia pushed through and made certified peer supports a Medicaid billable service. Wendy is with the Department of Behavioral Health in Georgia and has now consulted with, 30 or 40 states to help follow suit. So in most states, peer supports is reimbursable, and we see a growing body of work around that. To me, the biggest challenges are still cultural. It's not uncommon to have organizations either say that, well, we tried that peer thing, it didn't work for us, or they really are caught in stage 4, if you will, that they have some token representation of peers, but when you look at the actual engagement of services and care, it's a combination of 2, 4, and width. Look, I really appreciate Chief Corrigan. We have a number of really progressive law enforcement leaders and programs out there, but we shouldn't have law enforcement working with the front end response. And law enforcement didn't train. This is not what they signed up for, per se. Hospitals didn't sign up to all day long be doing clearance and evaluation for individuals who are having the worst day of their life from a mental health standpoint, not a medical emergency. So the cultural sort of responses to this, and there still continue to be pretty bold voices talking about, well, recovery is really a substance use thing, doesn't exist in the mental health space. Let's stop using the word recovery for mental health. I saw an article just a couple of years ago on the Huffington Post. The way that we really press this forward is by pushing through the discrimination. That's, to me, the largest piece. We tend to otherize mental health challenges in a way that breaking through that, people with their own lived experience, and frankly, people telling their own stories. Again, back to the 3,000 psychologists, 400 of which are not telling their own personal story for fear of the impact of that on their career or people thinking less of them. That's, to me, the most significant barrier that we've got to keep pushing through.
Thank you so much for that. Yep, here, I'm not on mute. Great. So, and I think that's one of the reasons that the Behavioral Health Planning Committee of Washington County Healthy Bodies, Healthy Minds, and the steering committee really decided that it was important that this plan be driven and developed by consumers and families and people in recovery, by the people who will use those services and systems and their family members. And so, I have one final question that I'd like to ask you. I've seen other presentations of yours, David, where you talk a lot about and show models around accountability. And accountability is a core priority and goal for us, and accountability in particular to quality of life, to the people who are using the system. And I'm wondering sort of what kinds of models of accountability have you used in your work that resonate in particular with people with lived experience and people in recovery?
So for us, it's really about the focus and the outcomes. I have been seeing this for years, this annual World Happiness Report. And I used to make fun of it because I have friends in Denmark, and Denmark was #1 for several years in a row on this survey. And I would always say to them, you guys drink more than anyone I know. You have huge debt. It's cold there, But a couple of years ago, I guess it was around the time that the ISMIC was working on this report for Congress, I happened to, for whatever reason, drill down on some of the correlates that they use to look at other data that pairs with their happiness survey. And they look at 4 items. They look at healthy lifespan at birth. In other words, how long are you living? We did this landmark work back almost 20 years ago now, which has led to much of the shift in the United States around integrated care. But it came from finding that people with serious mental illness died 25 years younger than the average American. And again, for a host of reasons, but primarily because of heart disease, cancer, suicide, accidents, from mostly avoidable, preventable sorts of challenges. The second thing that the World Happiness Survey looks at is GDP per capita. And they look at how much each household is bringing in. I think, at the end of the day, for us, it's about a sense of contribution that I'm making. For many Americans, for many of us, that is evidenced by employment. But contribution is more than employment. It's our sense that in the balance of life, we make a difference for those around us. But they also look at 2 other things. They look at social supports and connectedness. They actually ask just a single question. And that is, in a time of trouble, is there someone you can count on to support you, to be there? In Iceland, it's like 96, 97% of people say, yeah, I got somebody. But a person with serious mental illness is like, it's a little bit more than half, but just barely, that are going to say that. And then finally, they ask a question about autonomy. Can you say that you make most of the decisions over your life? Those 4 things correlate extraordinarily. I think Sweden was most recently the highest in their survey. We in the United States score well on a couple of those, not so well on a couple. But at the end of the day, those are the questions we need to shift a focus to. We want to talk about how many of our individualized service plans are properly dated and signed, and we get caught in process. We get caught, and even when we think we're focused on outcomes, we are back from that. So accountability for me is, Dr. Berwick would say, are we focused on a system that's safe, is cost efficient, and is effective? But the effectiveness is about, does it help the person live a full life? We've been talking about this for decades now. Charlie Curie at SAMHSA used to say that people with mental health challenges, substance use challenges, and suicidal challenges want the same thing all of us want. They want a job. They want a safe place to live. They want a date on Friday night. This is really, to me, what the accountability is about, is beginning to shift on that. And then the reality of what we currently do starts to, for me, it's putting ourselves, the reason Dr. Berwick became the innovator behind Zero Suicide and a lot of this other work is because he had lived this experience himself. One of his top critics landed up becoming a huge advocate at the very end of his life, but only because he was diagnosed with a very aggressive kind of cancer. It was given a very short time of live and experienced the healthcare system on the other side. When I was first at Magellan, one of my favorite things to do to understand this system better is to do an undercover boss type thing. Me and a patrol officer went out on a third shift through the middle of the night, and I wore jeans and a t-shirt. He was in a regular patrol officer uniform so that we could see the way the crisis system works firsthand. And then I said, okay, that's not a close enough view. I want to go through our court-ordered treatment process where you're picked up, you end up going to the state facility, spending 10, 12 days. I want to do that as an undercover guest patient. And I had 2 little children at the time, and my wife said, tell me what that would entail. So I talked about what I thought it would entail. I wasn't even sure. I knew what they told me, but I hadn't experienced it firsthand. And ultimately, I would have done it had I been single, but it was too much. So until we're willing to walk through these experiences ourselves, to me, that's the accountability, is that we begin to go through this. And there, again, pressing one step further, we still have a system where we have a ton of lived experience within our workforce of clinicians, doctors, and nurses already. But like Marsha Linehan, Marsha, one of the world's premier researchers in this space, went 50 years before disclosing her own lived experience for fear of the outcomes of this. So to me, those, Sarah, Susan, are the accountabilities that press us to the next level, of beginning to shift our focus and responsibility for the individuals who are receiving care, aligning with us that we're getting it right.
Thank you so much. And I'm not, we do need to segue to our panel. We have a really packed 2 hours, but before we do that, I just want to, hearing you speak about that was really powerful for me and reminded me of something that a mentor and friend of mine and a former board member of the Mental Health Association when I was there, Ed Ledoux, said to me. And Ed Ledoux he's passed away now, but he was the first executive director, maybe Jim will tell me, the second executive director of the Mental Health Consumer Advocates, which is now Oasis. And he said, providers want to measure how well treatment worked by reduction of my symptoms. But what I want is to know, is my life better? Am I better off? And it's such a simple statement, but it's so very, very powerful. Is my life better? Am I better off? And so that's one of the guiding stars that I tried to make sure we continued to focus on throughout this process. So now I think I'm going to pass it over to Susan. She's going to introduce the panelists, and thank you so much for this opportunity.
So thank you, Susan, for leading us in this important strategic planning process and discussion. Thank you, David. I knew you would give us a lot to dive into and to inspire us as we work to transform behavioral health in our region. Thank you, Jim, Erin, Magni, Sarah, and Mike, and so many family members and consumers who helped us create our plan. I now have the privilege of facilitating a panel discussion with 3 leaders at the federal, state, and local level to solicit thoughts and guidance to us as we work to implement our action plan. Let me first introduce them and welcome them to our panel. Tom Coder is Region 1 Administrator for the federal agency SAMHSA, the Substance Abuse Mental Health Services Administration. And prior to his job at SAMHSA, Tom worked as Senior Advisor to Rhode Island Governor Gina Raimondo and led the state's efforts to combat the opioid crisis. Tom has been a strong advocate and voice for recovery He no stranger to politics. Tom served in the Rhode Island Senate from 1995 to 2003 and chief of staff to the Senate president. So thank you so much, Tom, for being part
Thanks.
of
Good
our
morning,
panel.
Susan. Great to be here with you.
Great. Our next panelist, Catherine Power, has a long record of service and achievement in behavioral health and developmental disabilities. In January of this year, she was appointed as the director of the Rhode Island Department of Behavioral Health Care, Developmental Disabilities and Hospitals, a role she held before from 1993 to 2003, when she oversaw incredible innovation at the department at a time when recovery programming was beginning, deinstitutionalization, all of that, and now comes back to us again to help lead us now. Catherine had the position at SAMHSA before Tom did, and so she brings both this long history of experience in Rhode Island as well as at the federal level. And she's a retired captain in the U.S. Navy Reserve. Welcome, Catherine.
Thank you, Susan. It's delightful to be here with you and with my fellow panelists. Thank you very much.
Thank you. And finally, Elizabeth Roberts is the new director of the University of Rhode Island's Academic Health Collaborative, leading innovative cross-disciplinary health education programs and initiatives and fostering collaboration to improve community health outcomes. Elizabeth is also a veteran of healthcare. What a panel we have of healthcare policy, having worked tirelessly to increase health and dental health access for Rhode Island residents as a Rhode Island state senator, lieutenant governor, and later as secretary of Rhode Island Executive Office of Health and Human Services. URI's presence in the center of Washington County makes URI a very important local partner in our work, and we're excited to have Elizabeth joining us on our steering committee soon. So thank you, Elizabeth, for being on our panel also. So I'd like to begin by asking each of you to react to our proposed plan from both your personal and professional perspectives. What part of our plan really excites and resonates with you the most, and why? Tom, would you mind starting?
Sure, Susan. First of all, congratulations on the plan. It's amazing what you guys have come together to produce. I remember sitting with you a couple years back and talking about some of these issues, and you really expressing some frustration about what was available in Washington County. And to see you come together as a coalition and to be able to produce a plan like this is really amazing. So congratulations on that. The part of the plan that excites or resonates with me most, that's a real Sophie's choice, especially as the speakers have so elegantly provided all the evidence for each of the pieces of it, and really focused on the fact that this is a continuum of care, and the problems we're all trying to solve together, they're multifaceted and multidimensional, and so the solutions really have to be multifaceted and multidimensional. So the whole plan excites me. But of course, as a person in recovery, which means I haven't used alcohol or drugs since May 15th of 2003, my lived experience really pulled me toward the self-determination and inclusion section of the plan. People with lived experiences and families, they're valued, and they drive the design and delivery and the evaluation of new systems, as you talk about in that section. And it reminds me of the old phrase, nothing about us without us, that was coined by the mental health community many years ago. And you guys are not just giving lip service to that. You've actually set up an advisory committee. And as David talked about in his presentation, this is really peer-driven in many ways. However, there's one thing that stuck out to me that I wanted to just throw out for the panel and maybe get a little provocative on. It's the word that jumped out to me was consumer. Because in the addiction recovery space, we don't use that word. Bill White, who's a renowned recovery author, talks about that word being a misnomer because it implies that everybody that is part of that peer-driven system went through some kind of treatment, that they were a consumer of treatment services. And so he talks about the fact that it leaves out people who maybe didn't go to treatment or weren't involved in the system. So I think, as you go forward and think about this a little bit more, we want to include, if we're really going to break down the silos, we're going to break down negative public attitudes about addiction, about mental illness. We really need to see, this as an issue for everyone. David spoke about that, about the psychologist conference, right? Many of those folks may not have ever sought treatment, but they still had valuable experiences and things that they needed to offer. So as you go through this process, I just encourage you to think about that. And, Bill White talks about looking at more as a constituency representation or recovery representation, but find other ways to be more inclusive in the plan so that people just don't feel like, oh, that's not me. Like, I never consumed treatment services, so I'm not part of this. And I think that would be one way to broaden the group of people, the collaboration that you're trying to bring together.
Thank you for sharing that. That's a really good point. So thank you, Tom, for that. Catherine, what are your thoughts on this?
I have a couple thoughts. Thank you very much. And first of all, I want to congratulate Jim and Marcia for their leadership on this particular aspect of the work. And I'm actually going to get into a language issue, just like Tom did with my own language issues. And I think for me, I'm a student of transformation. So one of the things that I value in terms of this plan is that not only is its remarkable nature, but I'm using it as really a test point, one, to resonate against my department's strategic plan, which is what I did in terms of taking your pillars and resonating them against where we should go in our department. But I also see Washington County's plan as the kernel in which we may be able to resonate iterative transformation. So as Washington County goes, so will the state of Rhode Island, so will the New England region, so will the country, that you can use sort of the power of the communication, the power of the placement of the individual that you've engaged in our own specific roles. We can resonate and amplify the work that you're doing and bring that to bear, I think, in a host of other ways and a host of other constituencies and levels of government that I think really will be very powerful. So I want you to think about that. You're not just doing this for Washington County. You're really doing this as an innovative, creative, state-of-the-art way in which you are focusing on behavioral health that is centered on the lived experience. I think it's hugely powerful. One of the things that I think resonated for me, first of all, was because I've been in this so long, I'm very old, and because I've been in this so long, the piece that resonates for me is culture change, because that has been the most recalcitrant is the word I can think of. That has been the most difficult to have large bodies of people embrace it. And I used to talk to people and say, our mantra is mental health is essential to health. Mental health is essential to health. Mental health is fundamental to well-being. That was the first Surgeon General's report. And I'll tell you that when everyone in America believes that and states that, I can quietly go away. But until that time, nobody gets it, and nobody gets the commonality of these conditions. I am appalled that the information about how the fundamental nature of mental health is fundamental to your overall health, but the lack of understanding about the commonality of these behavioral health conditions is really quite amazing. So for me, the fact that you have a fundamental belief in culture change and in looking at how culture change is important in terms of it's the bedrock. It is the bedrock upon which anything else rests, even though I walked very carefully through the other pillars. The self-determination and inclusion, very powerful in terms of our belief in choice and person-centered care, obviously. And your pillar on parity in treatment, totally important. I thought Susan's observation about who's accountable for parity enforcement and parity compliance, a huge question nationally. And I'm sure Tom would say the same thing. We need to figure that out, and maybe Washington County can help us figure that out. And the notion that we are still trying to focus on evidence-based practices is really clearly important, that the state of the art changes over time. We have to keep on focusing on what's the best evidence-based practice that, as David indicated, has to be peer-driven. And we have a lot to learn yet about how peer-driven evidence-based practices go through a process of discovery and intervention and replication, frankly, across the system. And certainly your crisis system pillar, I think, aligns with this notion about safety and making sure that people are connected to treatment and recovery. But let me just add as a final thought, the piece that really resonates me in terms of culture change is that when David quoted Charlie Curie, who, by the way, hired me at SAMHSA, and they talked about, a job, a home, and a date on Friday night, Charlie used to say that all the time. And we used to say, that's why at that time, SAMHSA had programs like permanent supported housing. They had programs like supported employment. They had programs that really looked to those aspects of employment and housing as fundamental to the opportunity for the behavioral health system to respond. You don't have those things present, then you're constantly circling around trying to get people safe, trying to get people stable, trying to get people centered so that they can, in fact, address their behavioral health issues. So for me, it's always been, we need to really focus on the lack of housing options that exist in Rhode Island, and we really need to look at that very closely. And it's, of course, across the state, it's, of course, across the region in many cases. And it is the one area, both housing and employment, where often people get stuck. They can't move from one point to the other in the system, or they feel that they have to focus on a particular aspect of their life, and therefore they can't take care of themselves in terms of their own health. But I'm very powerfully moved by the fact that you're looking at culture change. And my final thought is around language. I think Tom and I are obsessive compulsive about these issues about language all the time.
Words matter.
I have always said, why do we use the term consumer advisory? Always. I was at the point where we mandated that community mental health centers had to have consumer advisory groups. First of all, the word consumer, I'll resonate with Tom, is outdated in some ways, but we always said they were advisory. Wait a minute, no, they're in the leadership position. They should be the ones, if this is a peer-driven system, this should be a peer leadership council rather than something else. And
excellent point.
And so I've always felt like, wait a minute, I had people who worked for me who at SAMHSA who said, no, Catherine, you may be the director, but I should be leading the Center for Mental Health Services because I'm a person in recovery. That is the way people should think. And so I'll stop there.
That's terrific. Thank you so much.
David's water freezing comment really resonated with me, Catherine, about that.
Yes, absolutely. Yeah.
Yeah. And the issue of housing came out loud and strong, and was one that we just couldn't take on in this plan. Right. But it's critical, no doubt about it.
And we want to help with you and support that thinking. I mean, I think my department has a role, obviously, to work with you on that. So we will do so.
That's terrific. Elizabeth, what are your thoughts?
Well, actually, I can't resist commenting on what was just talked about housing, and I want to add employment. Because when David Covington talked about, there's a reason you're there. There's a reason that you're contributing. From my personal experience with friendship, that people who don't have that or denied that because of mental illness, that is a difficult, it has impacts on how they live, but it also has a very deep impact on their experience of themselves. And I think we need to prioritize that as well. But let me get back to my real job, why I'm here. And I'm delighted. I am definitely not an expert as my fellow panelists are, but I'm really delighted in my new role at the University of Rhode Island that I'm going to be serving on the steering committee. So this is kind of my debut with the steering committee. I haven't even been to a meeting yet, but I really can't thank our speakers this morning enough for really giving me about the best first meeting I could have. And also the opportunity to really think about how URI and this work should be connected. And I was looking at the goals and I see two important ones for us, and I'm sure I will learn more today and in the future. And one is around the culture change, because we are a good sized community that happens to somewhat live, I think, in its own little world in South County. But it is a big community where we have a responsibility to be part of that culture change. And mental health first aid and a number of other projects on campus have really brought that to students and staff. But I think it's going to be important for us to think about that we have a responsibility. And I think right now, especially, because even though we have fewer people on campus right now, I actually think we have more people who may be of need on campus, and moving beyond some of this and really confronting it directly, this stigma where people will feel that can't be something I can talk about, that can't be something that, you know, that is okay. We need to move beyond that, because otherwise there's a lot of damage that will occur. And so the other place I see us, and I know in this plan, some of our faculty was very engaged, Karen McCurdy, Molly Greeny. I know that Lindsay also is very active through the psychological, and I got all my language wrong here, but our consulting, our program here at URI. URI, not the counseling service, psychological counseling center. Thank you. I've got to get all my language correct. But we also train enormous numbers of professionals in this field, both in nursing, also in pharmacy, something we don't talk about too much, but actually came up in Erin's remarks, that families and couples therapists, psychologists, we train a lot of people, and we have an important role to play in supporting this effort, both through our faculty and through the people that we are training. And I would say, listening to this, perhaps we will have things to learn from this effort as being part of it. You know, as we want a system to change, those who are working in the system need to change and understand what the new and different ways of thinking about mental health and mental health delivery services are going to be really important for us. So it's an important partnership for the university, and I think it will be a two-way partnership, which I think is very important. And I really appreciated David's kind of how we've progressed, the width, and then the kind of little bit of a partnership, and then really a peer-led approach. These are fundamental changes that I think many of us will welcome, and others will need to learn. And so it's really going to be a great opportunity for us at the university. So thank you.
No question about it. It is. Thank you for that, Elizabeth. This is a bold plan, and how we get to that tipping point where the water's frozen, where people understand what mental health and substance abuse means, how we shift our culture, how we have the services available, how peers are leaders, you know, is really going to be challenging, and we're going to need resources to be able to do that. And so I know now our time is getting short, but I guess briefly, can each of you speak to, you know, what resources you think we might be able to leverage or tap into to help us execute this plan? Tom?
Why are you looking at me, Sue?
Well, I'm going to ask each of you.
As the SAMHSA guy on the panel now, and thank you, Catherine, very much. This used to be your previous role. I think that, many of the programmatic goals that you have in the plan line up nicely with some of the federal funding that exists. SAMHSA has many discretionary grant programs that I'd encourage you to look at, and I'm happy to work offline with the advisory group of the initiative to determine which ones may be the best fits. Also, SAMHSA puts out what they call a forecast every year, where you can look and see what's coming up for grant-related activities. That's always posted on the website. But some of these discretionary grant programs, they're far out. They require, your application process. They require to get an award and then to start to put things together. And so some of that may be appropriate, and some you may need to look to more of the formula grant monies that exist through the department. SAMHSA, makes Congress actually, and I know you're going to hear from Senator Reid shortly, makes appropriations to SAMHSA that then get sent to the states in the form of block grants and other formula grant programs that may be appropriate for some of the activities you're looking at as well.
Thanks so much, Tom, for that. Catherine, can you chime in here?
I can, and I have actually a pretty extensive list that my staff put together for me in terms of talking about where you might want to look for resources. So I think for the sake of time, Susan, I'd rather send that to you by email.
Okay.
And because if I talked it, then I would take more time, and I think you're looking at time, and I want Elizabeth to have a shot at this. But just I'll send you some of the ideas we had, and it ranged from getting engaged with the Words Matter pledge and the Language Matters pledge as a part of the cultural change shift. Very powerful movement that's going on right now in terms of words matter and language matter. And I think that's a piece that it would be great if Washington County was participating in that process for your culture change pillar. I know you're tied very closely to the regional prevention task forces, so I know you're doing that work. There's also the governor's initiative on recovery-friendly workplaces. And so making sure that we get you connected to the governor's initiative so that all of the workplaces in Washington County have a chance to join that process. It's a very deliberative process on getting businesses to claim their participation as a recovery-friendly workplace. I think that would, again, that would help build some of the culture change issues, and I think leverage some of that. And then for each pillar, my staff gave me some connections with addresses for associations or addresses with philanthropy that you might want to connect to. And clearly, one of the governor's opioid prevention task force has a family task force that is a very powerful peer organization of individuals whose family members have been involved with addiction or substance use disorder. They are the kind of people that we want you to be connected to as well, so that their participation, I think, would again help with that communication, culture change, but the lived experience piece being so important, not just for peers, but also for family members. It's tremendously important, and family members have for a long time not been included. So Susan, for each of the pillars, I will send you that link. I will send you those links.
I'm so excited, and I'm so excited that everyone is so pleased and eager to help us in implementing the plan. We're getting significantly behind time, and so I'm going to move things along. I did notice that Jim McNulty wanted me to acknowledge that They use the term consumer because people with lived experience, people in recovery and their families asked us to do that. And the term consumer and customer has a power dynamic inherent in the word that peer still does not. And so it's a discussion that we clearly need to continue to have to choose the right language. Elizabeth, do you have anything more that you'd like to add in the few seconds before we shift to Senator Reid?
I will be very brief and say we have people. We have committed people. We have engaged people. We have professionally talented people. We have caring people, and they will come. Let me add one other thing, that we have some federal grants which we may match each other up. We have a community first responder overdose prevention grant, for example, that I think it will be a great partnership to bring some things like that out in partnership.
That's terrific.
They could have started the video.
Thank you all for being part of our panel.
Elizabeth and Catherine, thank you so much, Sue.
Yes, we will definitely be in touch. No question about it. We're going to be counting on you to help us implement this bold plan.
Of course.
Thank you so much. Thank you. And now I have the great honor and privilege to introduce someone to you who you all know and who we all are so incredibly lucky to have as our senior senator. He's been a real leader on issues that are important to healthy bodies, healthy minds, and including access to health care, mental health services on college campuses, mental health services for veterans, opioid treatment and recovery supports, early childhood mental health. He's recently worked to pass the National Suicide Hotline Designation Act of 2020 that not only established 988 as the National Suicide Hotline number, but provides a funding stream for mobile crisis services. So without further ado, Senator Reid, tell us what really excites you and resonates with you about our plan and how you can support us in implementing it. Senator Reid.
Thank you, Sue, for that very, very kind introduction, and more importantly, for your incredibly farsighted and thoughtful strategic plan for Washington County, which will be a model not just for the state of Rhode Island, but for the United States. I also have to recognize my colleagues, Tom Credere, Catherine Powers, Elizabeth Roberts, and David Covington. And with Tom and Catherine, Elizabeth, it's like old home days. I had the privilege of learning a lot when I was a young guy from those very three talented people, and I thank them, and they're still working for the people of Rhode Island. We all hope that someday we'll celebrate the success of your plan in person, not virtually when COVID is something in the past. But Washington County and your coalition has really stepped forward and made a great, great contribution. As you mentioned, one of the areas that I've been very much focused upon is the tragic increase of suicides, which is a serious aspect of the mental illness problem that we're seeing throughout the country. On a national level, youth suicide spiked from 2007 to 2017. It jumped 50%. And suicide is the second leading cause of death among teenagers aged 15 to 19. That's shocking, and it is a break somewhat from the past. That's not something that I sensed in my youth. And unfortunately, with the COVID epidemic, we're seeing more pressure and more crises and more problems. And no community is immune. It doesn't recognize racial boundaries, educational boundaries, income boundaries, et cetera. So we need to help. And as you pointed out, Sue, I was able to pass the National Suicide Prevention Lifeline, designating a simple 3-digit number, 988. So if anyone is out there being consumed by suicidal thoughts and suicidal impulses, please, 24/7, get 988, dial it, and get connected to trained professionals. I think it's going to make a real difference, and I'm very enthusiastic. But as you pointed out, a telephone number is no good unless there's someone at the end of that number that's a professional and trained. So we have to provide more resources for trained professionals to man these hotlines. SAMHSA has estimated we need about $50 million for the anticipated influx of 988 calls. And so we're working together with Congress to on a bipartisan basis to get the resources there so they can be available. And that's something we're going to be focused on as we go forward. I'm also working on resources for the Garrett Lee Smith Youth Suicide Prevention Programs, which are focused on college campuses. And in addition, we've introduced new legislation which would help prevention for suicide by screening and training in healthcare settings, giving individuals more insights as to people who might be manifesting suicidal tendencies and can be helped if these tendencies are identified. And one thing I want to say is that all of what we're talking about are, and Catherine made the point about the commonality between physical health and mental health. Mental health is the key to overall health. The Affordable Care Act, as well as the Mental Health Parity Act, are central, and the Affordable Care Act is under attack. The Trump administration tried to repeal it legislatively, and they failed because of the courage of John McCain. Now it's in the courts. On November 10th, and there very well may be a new justice there, on November 10th, they're going to start arguments on the constitutionality of affordable care. If that is knocked out, we are going to be in a very desperate situation nationally in many respects. Pre-existing conditions no longer are protected. 20 million people lose their insurance right off the bat. It'll be chaos. And that's a reason I think we have to be very sensitive about what's happening in the country. But let me just stop right there and commend you for what you've done. It's a remarkable demonstration of the Washington County's leadership, but not just statewide, but nationally. And thank you again, sir.
Thank you so much, Senator Reed, for taking the time to join us. I understand the 988 bill is on the president's desk. Do you think he's going to sign it? I sure hope he does.
I hope he does too, because it's such a sensible piece of legislation, and it's bipartisan. It got very strong support. So my hope is yes.
Yes, yes. Well, thank you for everything you do for us all the time. We're, like I said before, we're so lucky to have you, and as a partner and as a champion for us in Washington. Thanks again.
Thanks very much. Bye now.
Bye-bye.
Bye-bye.
So one of the things that we was really important to us was to honor the voices of youth in this plan. So I'd like to take 2 minutes to share the voices of youth, because they couldn't be with us this morning because they're in school and working. And so let's listen to what they have to say.
If I had known where and how to access mental health services, I would have gotten help sooner. I envision a community where we work together to support each other's mental health.
A place where all of us have adequate coping mechanisms for our daily stress.
This is a place where we encourage the normalization of sharing our inner thoughts and feelings and the tools that we need to help ourselves succeed. For when we influence others to do the same, we're creating a more inclusive and knowledgeable society and community where we welcome other people.
To me, a mental health positive community is one that educates youth about mental health, encourages discussions about mental health, and validates mental health experiences and struggles.
Is a stigma-free place with accessible resources.
I envision a future where all young people can get behavioral health services just like the ones that I received at Wood River Health.
I envision a world where there is no longer the fear of stigma keeping people from getting the help that they need.
That way, everyone can find the tools that they need to succeed in life and get the support that allows them to be their very best self.
Validate my stress. Validate my lived experience. We are not just the leaders of tomorrow, we're the leaders of today.
Invest in us. Invest in our mental health.
Thank you.
Our charge is clear now. It's been a very provocative and inspirational morning. Thank you all for being with us. We look forward to working with you to implement our plan. It'll take all of us to bring this plan to reality, and we really invite you to share your thoughts and get involved. As one final exercise, I'd like you to take a moment to think about this morning and share what words come to mind for you about our plan. Go to www.menti.com and use the code 5197983. Plug in some words and we'll leave with a terrific word cloud of our thoughts. I can't thank you enough to David Covington, to Tom Coderre, to Catherine Power, to Elizabeth Roberts, to Susan Jacobson, to our members of our Family Consumer Advisory Committee, Jim, Marcia, Erin, Sarah, Magni, Mike. Thank you so much for presenting today and helping us, guiding us through this process. You can find our plan at the Healthy Bodies, Healthy Minds website. You can find an opportunity to connect with others at our website, ourbodies.org. ourbodiesminds.org. So go there, you can complete a survey, give us information about how you'd like to be involved or what you think our priorities would be. We want to hear from you. It's really looking great. Thank you so much for participating. I hope you all have a great day.